Welcome back to the Pediatric Sedation Anesthesia course. We're focusing on Module 12 today. I'm Gary Badger, pediatric dentist, professor of pediatric dentistry at the University of Texas, School of Dentistry in Houston.
I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. Section Overview. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for the various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board of Dental Examiners Rules 110.17. Sedation anesthesia of pediatric patients.
Welcome to the Pediatric Dentistry Anesthesia course. We are focusing on Module 12 today, Sedation Anesthesia Record Keeping. Images used in this presentation are taken from non-copyrighted sources in electronic media and attributed as possible. The de-identified images are provided as an educational resource to illustrate techniques and procedures for clarity. The objectives of today's module: the participant should be able to know what sedation documents are needed, know how to record information to record, to be able to accurately track procedures safely. Patient selection for sedation. Patients that require sedation are those that have been unable to tolerate routine outpatient procedures and traditional behavioral guidance techniques. Other categories are those with special health care needs, those that have been referred to your office with advice to sedate, or those patients with large amounts of treatment needed coming from a distance. Documented justification for sedation is needed. Patient selection. Some children who present for dental care under sedation come from long distances and would prefer to have all treatments done rather than have 4 to 5 separate appointments scheduled. This particular situation solves the travel, school, and job absence concerns of the parents and should be addressed. Pre-treatment considerations. It is appropriate to evaluate patients for sedation personally before scheduling for sedation. Often, inexperienced dentists refer a patient that they have been unable to treat and recommend sedation or hospitalization. When interviewing the family and child, one may find that sedation is not needed. Parents must be informed of the risks of sedation and given time to decide if this is a good alternative for their child. Pre-treatment considerations. Some emergency patients arrive at your office for immediate care, and it is in your best interest to follow the protocol you have developed and schedule a future time because of consents, NPO status, and outright safety. If an urgent patient treatment is needed, consider asking your closest emergency room to help with sedation there, if treatment can be rendered there. Sedation record. The American Academy of Pediatric Dentistry sedation record is divided into sections within one document: patient selection criteria, assessment on day of sedation, drug dosage calculation, intraoperative and postoperative monitoring, discharge, post-op call. The American Academy of Pediatric Dentistry is recognized nationally as the model for pediatric sedation. Patient selection criteria. The selection of pediatric patients for sedation is a clinical decision guided by strict criteria which allows safe sedations to occur while minimizing risk. The record has a place for documenting the indications for sedation. fearful or anxious patients for whom basic behavior guidance techniques have not been successful, patients unable to cooperate due to lack of psychological or emotional maturity and/or mental, physical, or medical disabilities, to protect patients' developing psyche, to reduce patients' medical risk. Patient sedation selection criteria. A review of systems of the medical history prior to the selection of the patient allows an updated look at the patient's physiology, medical complications, and psychological preparedness for sedation, minimizing risk factors and emphasizing the benefit to the patient to reduce pain and improve oral health for improved function. The American Society of Anesthesiology classification channels low-risk patients 1 and 2 to outpatient treatment, plan development, pre-op and post-op instructions or precautions. This is a vision and view of the sedation record. The sedation record is comprised of patient selection criteria, and we will discuss those separately. Justification for sedation. Fearful or anxious patient for whom basic behavioral guidance techniques have not been successful. Patients unable to cooperate due to lack of psychological or emotional maturity and/or mental, physical, or medical disability. To protect the patient's developing disability. To reduce patient's medical risk. Treatment plans must be reviewed by caretakers in the following manner. Informed consent is obtained from, and the letter is blank to fill that in with the patient's initials or name. Pre-op instructions reviewed with, again, a place to place the patient's initials or name. And post-op instructions were reviewed with, and a place again for patient's initials or name. The name in relation to the patient, the initials, the date, and by whom in the practice was this information gathered. The day of checklist allows last-minute medical history and review of systems update. Occasionally, patients will have developed an upper respiratory infection with stridor or wheezing, asthmatic conditions worsen, NPO status has been violated, tonsils have enlarged, increasing risk, or patient's weight increases the risk factors. Vital signs are established, behavioral estimations are made, and final questions are answered. The assessment day of is a portion of the sedation record that allows for the interrelationship. It allows for the addition of recording information to the assessment day of and allows for many updates for medical history or review of systems update, the NPO status, the airway assessment, and the checklist. Vital signs are recorded underneath this section, and there's an area for comments. Pre-sedation cooperative level, unable or unwilling to cooperate, rarely follows request or cooperates with prompting or cooperates freely. Behavioral interaction is definitely shy and withdrawn, somewhat shy or approachable, and the guardian was provided an opportunity to answer all questions, appeared to understand, and reaffirms consensus for sedation, a place to say yes or no. Information for the guardian. The guardian was provided an opportunity to ask questions and appeared to understand and reaffirms consent for sedation on the day of sedation. This is an important opportunity for a guardian to have another chance to think over the consent form and whether this is the position that they would like to take. How long will it take? When to come again? What can be used for pain and how long? When he or she will go back to school? What and when to feed the child? The pre-sedation cooperative level. Cooperation, the patient is unable or unwilling to cooperate. Many patients who come in one day will have behavior of one type one day, and on the next opportunity, they may not be willing to cooperate. They have learned from being with a doctor and care provider if they are willing to cooperate the next appointment or not, or unable to do so. Rarely following requests, when patients are asked to sit still, hold their hands in their lap, open their mouth widely, they may or may not accomplish that or be willing to do that, and it's important to find that out in pre-sedation cooperation levels. The patient may cooperate with prompting, such as open your mouth, let me help you get that done, or cooperates with prompting when you say, let's work together to get this done. Or they may cooperate freely, volunteering to open up their mouth very widely or sitting very still, keeping their hands folded in the lap. The behavioral interaction is important to note. We know from scientific studies that definitely shy children have a very difficult time complying with requests in strange circumstances with people they don't know well. They could be somewhat shy and still refer to mom or dad, whoever's there accompanying them at that day, looking to see and get approval if that's all right. And finally, the patient may be totally approachable, and that's something to notate on this chart. Drug dosage calculation. This important procedure allows the operator to calmly prepare the proper dosage of the correct drug to be calculated along with the rescue or antagonist for administration route. Maximum amounts are considered based upon weight and temperament. The maximum dosage of local anesthetics, indicating the max amount of corpules to be used, needs to be annotated within the sedation record. The procedure must be stopped if the level of anesthesia goes beyond the intended level permitted. Administration of medications. Parents have been informed about the method of drug delivery and are reminded of the procedure prior to administration. The inhalation drugs, will the patient use the mask or nasal tubing? Oral approach, will the patient take the medication? The intranasal is reserved for those patients who may not be able to cooperate and will allow the patient to cooperate for bilateral nares dosaging and momentary stinging of the medication as it's sprayed and injected into the nares. Administration of drugs can be intramuscular. Is the child dressed to receive either deltoid or vastus injections? Intravenous. Will the child take the oral medication to prepare for IV sedation? Or suppository? Will the child be able to assist with this modality, and will the parent assist or permit this to happen? These administrations of drugs has a clear portion of the sedation record to place the agent. As you see in the chart that's listed here, the agents have places for 3 types of medications. The routes in which the medications are taken, is it going to be oral, intranasal, suppository, IV, IM, and the location for the kilogram weight of the patient to calculate the dosage in a milligram per kilogram portion. Once the total milligrams are determined, the dosage concentrations are registered in milligrams per milliliter, and it allows us to draw up medications that are liquid on a milliliter basis. The emergency reversal drugs are available for narcotics. We have naloxone, which can be delivered IM, IV, or sub-Q, and that dose is 0.1 milligrams per kilogram times the kilogram weight equals the number of milligrams, and its maximum dosage of 2 milligrams that may be repeated every 2 to 3 minutes during rescue. For benzodiazepine, flumazenil IV is preferred, but can be administered intramuscularly. The dose is 0.01 milligrams per kilogram times the kilogram weight equals a milligram amount, and that maximum dose is 0.2 milligrams, which may be repeated up to 4 times. Local anesthetic Maximum dosages are based upon weight. Lidocaine, for example, has 34 milligrams per 1.7 mLs per cartridge, and the 4.4 milligrams per kilogram times the kilogram weight of the patient yields the milligrams divided by the milligrams on the carpule will tell us how many carpules are available for dosage. The other available local anesthetics may be used and the dosages are listed there. Intraoperative management and post-operative monitoring requires the registration of the EMS telephone number in case some inadvertent event would be occurring. The monitors are listed as observation, which should typically be done routinely, pulse oximetry, which can be attached when the patient is moved to the chair, precordial, pretracheal stethoscope is used to listen to the heart or the lungs and their oxygen exchange. The blood pressure cuff is attached to the patient's arm in the upper portion, one that's properly sized for 1/3 of the distance between the elbow and the shoulder. A capnograph, which is the measurement of carbon dioxide exhalation, can be attached by holding the tubes to the nares for the exhalation and the gathering of the exhaled carbon dioxide. EKG is available for patients who may have heart conditions, and a thermometer is available to determine if the patient has an ongoing temperature or does the temperature reach the levels that are expected for a healthy, normal child. Protective stabilization devices such as the papoose, a head positioner, is being manually held in active protective stabilization. The neck and shoulder roll, mouth prop, the dental dam that's available. The recording is a 10-minute interval starting at a baseline. The baseline vitals are recorded, and it's nice to have those to compare with those that were done preoperatively, but there's a portion here where we can talk about nitrous oxide percentages and local anesthetics in milligrams. The SpO2 is measured from the pulse oximetry. The pulse is also measured using that same machine. The blood pressure is taken by the blood pressure cuff. Respirations are noted by counting at least for 6 seconds and multiplying by 10 to achieve the respiratory rate. Carbon dioxide is achieved through the capnography. There's a place for procedures to be noted, comments, sedation level, and behavior. A place for agents to be listed with the route, the dose, the time, and administered by whom. Local anesthetic agent, a record of the dental procedure start and completion times and transferred to recovery times, and there's a location for 4 letters to be placed on the chart corresponding to comments, for example, complications or side effects or airway intervention, reversal agents and analgesics, etc. below. How to fill out the sedation record. Each block, as I have mentioned, must have a 10-minute increment written at the top of the chart. As you go across the chart, you can note the time and enter that in your baseline area when the vitals are being taken, and then you can go to the level once the sedation agents have been administered at the time increment that is mentioned at the top of the page. The baseline vitals are to be recorded. Then record procedure start and completion times, drugs listed and times of administration, and the local anesthetic, how drugs are administered, the dose and time, and by whom, and comments for events that may have occurred. Intraoperative management requires the EMS phone number to be listed in case of emergency. Monitors checklist, observation, pulse oximeter, blood pressure cuff, capnography, EKG, and thermometers, opportunities to list those, precordial or pretracheal stethoscope, and protective stabilization. Protective stabilization comes in various forms. The typical one we see in training programs is the papoose, and that's available in another form called a joey board, which is another type of passive restraining device. A head positioner, manually holding the patient's hands or across their elbows to keep them from raising them during the administration of medications. A neck or shoulder roll is provided. Mouth prop, McKesson, and a MOLT, or a scissors grip, which is an active position that the care provider can use to open the patient's mouth. A dental dam, and other things such as knee-to-knee exam, a blanket, and a towel. The knee-to-knee stabilization is currently being reviewed by the Texas Board of Dental Examiners to determine if there is a role for them to play in the supervision of this modality, and it remains to be seen exactly what their position will be on that. Intraoperative documentation. The document time-oriented record is a running narrative of what is happening during the sedation portion of the treatment. Its details are often overlooked by doctors and minimal information is provided. However, if an incident occurs, then all necessary information is needed to account for the treatment rendered and its justification. I've had the experience of reviewing charts of doctors who have had sedation records evaluated, and it appears as though a legible signature is important to do that, and that all information that's on there in this medical legal document needs to be signed by the doctor for verification. The second assistant with BLS training is used to document the moderate sedation. In moderate sedation cases, it's important to have 3 people present. One is the doctor, the other is a first dental assistant, and the second dental assistant is used to record all procedures. The patient's name and demographic information is added there, but as well the assistants that are attending with the doctor, their names or initials need to be added. The second assistant with the training will be recording the moderate sedation procedures and adhere to the rule of entries that are no longer than every 10 minutes. This person is charged to watch for changes in the vital signs and to notice downturns that may compromise the patient, such as the coloration around the lips or the eyelids or the other colorations of the patient's face and around their nares. The clinician must be informed routinely about the status of the patient. Discharge. The discharge section of the sedation record allows one to determine the return of physiologic parameters to the pre-sedation levels, and or a statement of alertness to ambulate, carry on a conversation, and to stay awake without prompting for 20 minutes. Post-operative instructions documentation is recorded, both written and verbal, understanding of discharge instructions, and receipt of the patient record. Oxygen and suction must be present in the recovery area if a separate recovery area is necessary. All documents in the discharge need signatures in the document. The document must have the names of the doctor and individuals present during the administration of drugs. If documents ask for a staff member's name or initials, then it must be in the final document and signed off by the patient's caretaker. The qualified dentist must monitor the patient during recovery until the patient is ready for discharge by the dentist. The dentist must not leave the operatory during sedation and may delegate the discharge of the patient to an auxiliary when the patient is ready by discharge criteria. The patient's level of consciousness, oxygenation, ventilation, and circulation must be determined by the treating dentist. Therefore, it's imperative that the dentist remember, do not leave the operatory during the sedation at any time, not to get a sandwich, not to go to the bathroom, or any time. This is according to the rules of the TSBDE. The discharge has a portion on the dental chart to record the criteria for discharge. In this particular instance, cardiovascular function is satisfactory and stable. The protective reflexes are intact. The airway patency is satisfactory and stable. The patient can talk, return to pre-sedation levels. Patient is easily arousable. The patient can sit up unaided and return to pre-sedation levels. The responsiveness is at or very near pre-sedation levels, and the state of hydration is adequate, especially if the patient's very young and special needs child incapable of usually expected responses. To the right-hand side, we'll see the discharge vital signs, the pulse rate, the saturation of oxygen, blood pressure, respirations, and temperature. The discharge process entails post-operative instructions reviewed with the care provider, who that might be, by either the doctor or the assistant. If this patient is ready for discharge, then it's likely that a staff member may be interviewing the patient with this information. Transportation arrangements have been made, airway protection in observation of the activity, diet, nausea and vomiting, any fever, any prescriptions that are going to be supplied for the patient, and the anesthetized tissues need to be addressed in the postoperative instructions to warn the parent not to allow the child to chew or scratch or bite on their lips, and the dental treatment rendered. Is there going to be pain? Is there going to be any bleeding or any other information that the parent needs to know, including emergency contact? The next appointment on a specific date for follow-up, and who was the one that took the information for. And the patient signs, I have received and understand these discharge instructions. The patient is discharged into my care at whatever time, AM or PM. The signature, relationship, mom, father, caretaker, and the after hours number so that the patient can be reached for an evening follow-up. The operator's signature, usually the dentist, is there. The chairside assistant's position for writing their initials or name, and monitoring personnel need to provide a signature or initials at that location. It's really best to have the name of the person who's assisting you there, so if some question comes as to who was there and recalling the events, the person who was there can be contacted. It'll be important to make sure that each one has a legible signature to be able to be available for these situations. Postoperative call, a place to record when that was taking place, who did it, what time, what was the date, who was spoken to, and any comments about the character of the conversation. Discharge criteria. These are all listed on the dental chart. Such things as protective reflexes are intact, the patient can talk, return to pre-sedation levels, the patient can sit up unaided, can stay awake, the hydration is good, the patient's very cooperative, following instructions, and a place for the vitals to be discharged, values placed in the chart. The postoperative conversation with the parent can vary from patient to patient. The conversation with the parent immediately after surgery is an important conveyance to be expressed appropriately. It should contain a happy comment that the child was cooperative for the medication administration, the sedation was good, a comment about the quality of the work such as, "I'm sure you will be happy with the appearance or outcome," or "you will be happy when you see what we have done for your child." This sets the tone when you first visit with the parent after sedation and allows a conversation to take place by using these opening comments. The parental conversation has topics that should be covered. Comfort of the patient during sedation. What can the parent expect? Will they be laying on a chair? Will they be sitting upright? Where will they be? And in the cases of using protective stabilization, it's a pretty soft board to have the patient lay on. Any expected discomfort and how to handle that or how it will be handled when the patient can expect, and postoperatively how it was handled. Expectations of future discomfort. Once this heals, will there be discomfort upon eating? Once the patient gets home, are they going to be able to eat something, rehydrate themselves? And all related to the function of the teeth. What about the replacement of primary teeth? When they're lost, when will the permanent teeth erupt or come in? If there's premature removal of a primary tooth, what will be done? Will there be a space maintainer? Is a space maintainer needed? And generally, the answer to that is yes. And when will that be placed? And can that be handled on an outpatient basis once the patient heals up from a tooth extraction? A post-op visit is scheduled to allow the parent to have this condition checked, and that's something to talk to the parent about, or the patient, or both, at the time the patient has gone to recovery. What are the aesthetics concerns about the parent? How will it look? As you discuss this preoperatively, it's important to discuss immediately postoperatively how happy you are with the treatment that was provided. The durability, how long will it last? How long will the filling stay in? Is it possible the fillings could be lost? If so, it must be disclosed to the parent, because crowns or fillings are not permanent. They're in there for a period of time to make sure that future tooth decay doesn't get worse on this particular tooth, and durability is important to talk to about. Reinforced changes, for example, what's going to happen with the oral hygiene now that everything is taken care of? Is the diet going to change and improve and be monitored by the parent? What about the application of fluorides? Are they drinking fluoridated water? Do they have a fluoride rinse? Do they need to take fluoride tablets? All of this needs to be discussed with the parent in the post-op conversation. Loss of crowns due to diet. Children who have crowns placed on the teeth can have them dislodged if the child eats really sticky foods like Tootsie Rolls or gummy bears or something that's very sticky, popsicles that are suckers that get very sticky once they start to dissolve. So eliminating those from the patient's diet will ensure a greater period of success. How to treat any infections. Is it possible that infections may develop? Typically not, but if a patient has had a preoperative infection with one of their teeth, they may still be on some antibiotics. When can they see their child? They want to see how the child is doing. When you've told them how well the child did, they want to look for themselves and be there to reassure their child that they're coming back to the parent and everything is going to be okay. And the expectations of behavior after sedation or OR. Will there be a reaction to the sedations or the operating room treatment? The patient's had general anesthesia. What are the expectations of the behavior? Some parents have indicated that their child, if they've been at one level cognitively, that for a little while they appear a little bit later to be not as advanced as they once were. So this might be something to bring up to the parents to discuss. Postoperative call. Is it necessary to call and see what's going on? Using a postoperative call by yourself or your staff member allows the patient to understand a feeling that you really care for what's going on with the child, and it allows you to transmit information that might be useful to the caretaker once they have some questions that has occurred to them after they get home. So the patient's caretaker is contacted by phone after the treatment. This has been arranged in advance to ensure the caretaker receives the call. The cell number is attained and put into the sedation record. This opportunity provides essential postoperative conditions exhibited by the patient for full recovery. If another sedation is needed, it will allow one to evaluate the regimen used to determine if the dosages were effective. For example, you might say, how did your child do once they got home? Did they sleep? And often they do. or was your child fully awake, and did the sedation make them behave in a different way that's not acceptable to the parents? That's good to discuss because it may influence one in the next sedation and what can be done to improve it for the parents and the child. Recording agents used. Beneath the sedation chart is the location where drugs are listed with route, dose, time, and who administered. Local anesthetic agent is noted. The dental procedure start and completion times, transfer to recovery, sedation level, and behavior. At completion, one can evaluate the overall effectiveness. This last evaluation enables one to determine if dosages were effective for that procedure or was the drug effective for that child for that procedure. Here are some questions I'd like for you to ponder now that you've completed this module. Is the documentation of sedation treatment required by state law? The answer is yes. Is it necessary to be NPO to sedate children? Some studies have shown that NPO status may allow some consumption, but the risks of aspiration into the lungs is high and violation of the rule is not recommended. However, if urgent situations arise and a patient's going to the emergency department, it's important to think that sedation can be done. However, there will be risks that must be discussed with the parent regarding regurgitation and the possibility of aspiration of regurgitated contents. Can local anesthetics cause inadvertent, untoward effects? Yes. Local anesthetics are drugs that have actions centrally that start out as excitement, ending with depression and seizures. Dosages must be monitored when used with sedation medications. Must documents be signed by the dentist? Sedation records must be signed by the operating doctor and assistant's initials and/or name. This medical legal document is essential for protection of the patient as well as the doctor. If you need clarification of any of this information, please send an email to pace@uth.tmc.edu. Here we are in the reference section, and you want to continue to use these references to come up with some of these answers that will help you in your sedation with these patients. This completes this section of the course. It's time for you to take a short exam in order to complete the requirements for streaming video courses. And once you have completed that, the nature of the subject, you need to get a passing score of 80%. It's necessary in order for you to advance to the next section. Upon a successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you'll be instructed to take the exam, and a new set of questions will be provided. You'll have 3 chances to fulfill the requirements. If you're not successful, you'll be instructed to review this section again. Good luck on the exam. If you're ready to take it, the next section, upon the completion of the exam, you'll be provided a link to continue. If you wish to proceed at a later date, you will need to log in, and no further payment is necessary since this is a continuum.